Hello friends, how are you? Today we are going to start a new topic, that is analgesic, antipyretic and non-steroidal anti-inflammatory drug. This chapter we will deal in two parts. The first part over here we will see about the analgesic, antipyretic, what these are, non-steroidal anti-inflammatory drugs, and the drugs in from that drugs, only the salicylate type of drugs we will see in this chapter. In the next chapter, we will go for the remaining category of drugs, which are from these non-steroidal anti-inflammatory agents. As far as the learning outcomes for this chapter is concerned, upon completion of these two sessions, the students will be able to describe and define the pathophysiology behind the algesia, that is pain, fever, and inflammation. They can classify the various drugs which are used as a non-steroidal anti-inflammatory agents. They can predict the pharmacotherapy of non-steroidal anti-inflammatory agents, as well as they can predict the mechanism of action. They can describe the mechanism of action which is responsible for the non-steroidal anti-inflammatory actions of these drugs. Now, first part we will see what is the algesia or pain, we can say, the pathophysiology behind the pain. In short, we will see here. Pain is here, it is defined already, that is, it is an unpleasant sensation, sensory impulse or emotional experience. It might be a impulse which is generated from the surface, or it might be an emotional experience associated with actual or potential tissue damage. There might be potential tissue damage, or there might be an emotional experience only, so which is associated with the pain. And second part is nociceptors. These are nothing but the receptor, we can say, which are receiving the pain sensation, peripheral terminals or efferent fibers which are receiving this pain sensations. These pain sensations can be activated by different routes like heat, acid, or pressure, or inflammatory mediators. This is the main kind of a thing which is over here. And these inflammatory mediators, which might be bradykinin, cytokinins, or interleukins, like this way. There is also a liberation of a prostaglandin, which promote the hyperalgesia or increase in the pain, and they also, some of them also reduces the pain threshold, that is perception tendency, we can say, or threshold of the perception. There are some neuropeptides like substance P or calcitonin, which are also helping into the pain sensation. And this pain sensation is generally gene related peptides which is available in our body. Next is a pathophysiology of a fever as such. So we are very well known in anatomy physiology also. We have seen that is hypothalamus is playing a very important role in management of a body temperature. It regulates the body temperature by maintaining the balance between the heat production and heat loss. These two aspects are managed by the hypothalamus. Uh, in a fever, what happens is that this set point of set point is elevated. Set point in the hypothalamus is elevated. At the higher level it is set, and it is also known as hyperpyrexia or elevated body temperature. There are various reasons behind it, and most of the common reason amongst these is a tissue damage or infection or inflammation, inflammatory conditions, or if there is a something graft or something article which is fitted inside our body is been rejected. There can be a cancer, malignancy, or some disease conditions which are leading to the fever kind of conditions. So in a fever condition, there are enhanced cytokinins and interleukins level of our body. This cytokinin production produces prostaglandin in the hypothalamus and set the elevated body temperature, or the hypothalamic set point has been elevated. There is a disturbance in the heat regulatory mechanisms, and this is leading to the imbalance between the heat loss and heat production. Next is an inflammatory processes, anti-inflammatory inflammatory processes. What is the pathophysiology behind it? It is a reaction which is against the invasion of a noxious stimuli. Whenever there is a noxious stimuli inside our body, body shows some reaction to it, and this reaction is nothing but the inflammation. This involves the series of the event which is begun mainly from the tissue injury. Whenever there is an impact on the body, there is a tissue injury, and this is leading to the inflammatory process. Inflammation is manifested as erythema, edema, tenderness, hyperalgesia, or pain. There might be erythema, accumulation of a fluid, tenderness, or hyperalgesia means there is elevation in the localized temperature, and pain which is associated with the inflammation. Principally, this inflammation, occurrence of inflammation takes place in the three phases. In very first phase, there is a local vasodilation or increased capillary permeability. Then in the delayed phase, there is the infiltration of a leukocyte. That leukocyte will be inflated over and macrophages, and in a chronic or proliferative phase, the tissue degradation or fibrosis will be over there. Tissue degradation, there is a localized accumulation of a damaged tissue, that is a pus formation and fibrosis. So initially there is only redness or increased local permeability or edema like that. In delayed, there is a accumulation of leukocytes over there, migration of macrophages, and the damaged tissue will be accumulated in the third phase, and there is a pus formation or fibrosis which is taken place at the site of inflammation. Now, as far as the factors which are responsible for these inflammations are activated cell adhesion, which is mediated by platelet activating factors, cell adhesions factors which are enhanced over there. There is a leukotrienes, interleukins, histamine, bradykinins. These are levels, all the 5-HT and prostaglandin levels will be elevated, which is responsible and contributing for the inflammatory processes. Next is the non-steroidal anti-inflammatory drug. These are about the three categories: pain, fever, and the inflammations. So all these non-steroidal anti-inflammatory drugs will be used in these three conditions. What these drugs are? These are the chemically diverted compound. They do not have some structural similarity in this. So they have the different diversity in their chemically, and more of they are organic acids. Commonly they share a pharmacological property, that is analgesic, antipyretic, and anti-inflammatory in effect. Analgesic means which is reducing the pain, antipyretic means which reduces the fever, and anti-inflammatory means they reduces the inflammatory process. Generally they do not depress the CNS. They, although they are acting on the CNS oriented, they are not depressing the CNS, and they are weaker than morphine in reducing the pain kind of sensation or anti-inflammations. They are non-narcotic and non-opiates. So these are the principal features which are of the non-steroidal anti-inflammatory agents. They act on the CNS and rise the pain threshold. Therefore, the analgesic properties there. Peripherally, pain mechanism, they work peripherally also and reduces the inflammation also. Next to it, that there is one typical characteristic of a non-steroidal anti-inflammatory and the prostaglandin is that they block the cyclooxygenase enzyme. So where the cyclooxygenase is available, all over body the cyclooxygenase enzyme is available, which is responsible for conversion of arachidonic acid to the endoperoxide, and ultimately this endoperoxide will be converted to prostaglandins. So there are two forms of this cyclooxygenase which are responsible for the prostaglandin synthesis: COX-1 and COX-2. Cyclooxygenase enzyme, this COX-1 and COX-2. COX-1 is generally found in normal tissues, whereas COX-2s are responsible for the inflammation produces. So they are responsible for the cytokinins and other inflammatory mediator production. So COX-2 are more important as far as the inflammation is concerned, whereas a COX-1 is normally present in our body, and most of the time this COX-1 is responsible for cytoprotective action. So they produces the prostaglandin which is responsible for the protection of the cells. So this prostaglandin is playing dual role. They protect the cell as well as they also act as an inflammatory mediators. So whenever they are synthesized from COX-2, these cytokinins and prostaglandins and mediators, they work as an inflammatogen, whereas whenever they produce it are in the stomach from the COX-1, they produces a prostaglandin which is having the cytoprotective in nature. So COX-1 are cytoprotective, COX-2 are inflammagen, or they produces the inflammatory mediator. Non-selective inhibitors of these COX will have the anti-inflammatory property, but they inhibit the cytoprotection and may give you the gastrointestinal side effect. So this is what the mechanism which is responsible for it. If we see here, the arachidonic acid which is over here available, sorry friends, there is a little disturbance inside over here. The arachidonic acid is synthesized from the various phospholipids, then these by the lipooxygenase enzymes, and through the cyclooxygenase 1 and cyclooxygenase 2 pathway, they are producing the different autocoids. Cyclooxygenase 1 produces the prostaglandin, which are responsible for the housekeeping activity, cytoprotective activity, which are mainly synthesized into gastrointestinal tract, responsible for platelet aggregation and renal functions, whereas cyclooxygenase 2, it is responsible for mitogenesis or growth, or we can say the inflammatory processes which are responsible, renal function and other functions. So non-steroidal anti-inflammatory blocks both the cyclooxygenase 1 and cyclooxygenase 2, whereas corticosteroids block only the cyclooxygenase 2. So corticosteroids mainly used for the inflammation processes, but whenever we give the non-steroidal anti-inflammatory agent, they will block the cyclooxygenase 1 as well as 2. By the 2, they will give you the anti-inflammatory action. By blocking the cyclooxygenase 1, they will give you the gastrointestinal side effects. So specifically, the non-steroidal anti-inflammatory agents which are having only the specific cyclooxygenase 2 activity will be selected as an anti-inflammatory agent. Second aspect is COX and platelets. Platelets activation or platelet aggregation, it is mainly managed with the COX-1. So platelets contains the COX-1 as an agent which is responsible for prostaglandin synthesis. So prolonged aspirin, if you give to the human being in a low dose, it inhibits this COX-1 and irreversibly inactivate this enzyme. So the enzyme inactivation, COX-1 inhibition, is irreversible and inhibit the platelet aggregation. So platelet aggregation property of these which is induced by the thromboxanes synthesized from COX-1, it will be blocked by the aspirin kind of a compound. So aspirin block the COX-1, and by the blocking of the COX-1, thromboxane will not be synthesized, and after that platelet aggregation will not takes place. So aspirin act as a platelet aggregating blocker agent over here. And this blockade is irreversible, completely irreversible blockade. So this blockade will last for the lifetime of the platelet. That is, this lifespan of the platelet is around 8 days. So here we can say platelet turnover will be limited. Very small amount of COX-1 will be available into the that platelet, and therefore aspirin having a limited actions which is limited to that platelet, and this lasts for the 8 days only till the platelet will be there once it is irreversibly blocked. They block the thromboxane A2 production by blocking the COX-1, and thereby platelet activation factors will be reduced down, and thrombus formation will be possibility of a thrombus formation will be reduced. So thromboxane formation depend upon this activation of platelets by the COX-1. So single dose of a aspirin around 75 milligram inhibit the platelet COX for its lifetime of that particular platelet, which is around 8 to 11 days. Glucocorticoids also suppresses the COX-2 mediated prostaglandin inhibition and anti-inflammatory activity. And this is how the by COX-2 mechanism, it is not by COX-1 mechanism. As far as the classification of drug is concerned, this non-steroidal anti-inflammatory agents are divided into different classes over here, which is given and depends upon their chemical structures. For example, first one is the salicylates, which comprises of aspirin or sodium salicylate, then para-aminophenols, that is acetaminophen, or which we also call as a paracetamol, then indole acetic acid, example is indomethacin or sulindac, aryl acetic acid, example is diclofenac, aryl propionic acid, the example is ibuprofen or ketoprofen. Then next to it is antranilic acid like mefenic acid, enolic acid, pyridoxicam, alkanones like in nabitone, pyrazoles, phenylbutazones, and there is one separate category which is also called as a COX-2, specific COX-2 inhibitor. All above are the mixed COX-1 as well as COX-2 inhibitor. Second category is COX-2 inhibitor. Specifically, they are which comprises rosicoxib, roficoxib, celecoxib, or ketorolac. These or etorolac. These are the specific kind of compounds which have the ability to block only the COX-2 inhibitor. Very first drug we are going to start over here from this classification. In this presentation only we are taking the salicylates, and rest of the all other compounds we will take it to the second presentation. So first drug, that is a salicylate category, we will take it. It is one of the oldest kind of a drug which is available on the earth, we can say. Actually, it is obtained from the plant source Salix albica in 1980, 1999 it has found, 1899 it is found that this Salix albica containing one glycoside which is responsible for antipyretic action. But before that it is used actually. This plant has been used from almost all 1875. But 1899 it is found out that it contains glycoside which is responsible for antipyrine, antipyretic action of it. And initially it is known as salicine, which is upon hydrolysis give the salicylic acid and glucose. So salicylic acid, salicylene is nothing but the glycoside which is formed by salicylic acid and glucose. So salicylic acid is specifically highly irritant type of compound, and externally it is used nowadays as a keratolytic agent. This esters of this salicylic acid is also known as acetyl salicylic acid, acetylated salicylic acid, or ester of salicylic acid, which is popularly later on known as an aspirin, which is having a analgesic and antipyretic action. Then next compound is methyl salicylate, which is a volatile liquid or which is having a counter irritant property. Most of the topical creams where this salicylate methyl salicylate is used. Methyl salicylate is a counter irritant. Few other compounds are choline salicylate, choline magnesium salicylate, which are clinically useful as an analgesic or anti-inflammatory agents. So they possesses, the salicylates possesses the pain relieving capability in the low to moderate dose. That is the pain which is arrives from the skin, headache, myalgia, arthralgia, or pain from the inflammation, they will be relieved by the salicylate. As far as antipyretic action is concerned, they lower the body temperature. Elevated body temperature will be lowered using the salicylates. In a large dose, in fact, they produces the pyrexia. Large doses of the salicylate produces a pyrexia, whereas the low dose produces the antipyretic acid agent, antipyretic action. They facilitate the heat loss, vasodilation, and sweating. Vasodilation and sweating produces heat loss, and by that way they produces the antipyretic action. The hypothalamus, in previous slides only we have seen the hypothalamus, which is set at a higher level, it will be brought down to its normal level by the antipyretic action of the salicylates. In a high dose, they produces the CNS stimulation followed by depression. Higher toxic dose, they will produce the CNS stimulation first of all, followed by the depression, confusion, dizziness, tetanus, or high tone deafness. These are the side effect which is found on by the salicylate in the little bit higher dose. As far as these actions of the salicylate on the respiratory system is concerned, they stimulate the respiration and increases the oxygen consumption. Stimulation of respiration will obviously lead to the oxygen consumption and oxygen production. Stimulation of a respiratory center will be there, and by the respiratory center stimulation, the respiration will be stimulated, ultimately which is leading to the oxygen consumption and carbon dioxide production. Moderate increase in the rate and depth of respiration. Also high dose increases the respiratory minute volume. Respiratory alkalosis will be there. Mole of the alkali will be deposited in a respiratory center. Still higher dose if you take, then it will depress the medullary center and respiratory depression will occur. They have a typical side effect on acid base balance. As far as this salicylic acid is concerned, they are acidic in nature. but initially they produces the respiratory alkalosis as a compensatory mechanism. So they produces systemic acidosis, but as a compensatory mechanism they produces the respiratory alkalosis. Enhance the elimination of bicarbonate with the loss of sodium and potassium. They enhances the bicarbonate elimination, and the sodium and potassium loss will be there, and thereby they produces the uh, uh, what you can say systemic alkalosis. Plasma bicarbonate level will be reduced and blood pH will return to its normal level. In a toxic dose, they lower the blood pH, lower the bicarbonate, like metabolic acidosis. Acid base balance will be entirely disturbed over there. There is a change in electrolyte balance and water balance of our body. So this is the typical actions of these salicylates on acid base balance. As far as the action of this salicylate on CVS is concerned, no significant side effect on the CVS they have found out here. But in a few cases, in a few effect they are found, which is a peripheral vasodilation responsible for antipyretic action and all these things. If you are taken it is more than 3 grams, then there will be retention of electrolyte and water and increasing the plasma circulation. These kind of a side effect we will found. This effect we will found, not side effect. As far as the gastrointestinal effect is concerned, they produces the epigastric distress, that disturbances into the gastrointestinal tract, nausea, vomiting, gastric irritation. These are all combined together, heartburn, etc., known as epigastric distress. Dyspepsia, gastritis, gastric erosion, that is a detachment of the mucosal layer, ulceration, peptic ulcer, gastrointestinal bleeding. These kind of effects are seen whenever salicylates are taken. As far as the effect of salicylate on liver is concerned and renal metabolism is concerned, in a high dose they produces the hepatic injury. After several months of treatment, they produces the injury to the heart, retention of salt and water, reduction into the renal function test with the cerebrous CHF. Whenever there is congestive heart failure, the renal function test functions will be reduced. Papillary necrosis will be obtained, intestinal nephritis. Children's and geriatric patients are more susceptible as far as the renal effect is concerned. Salicylate produces a typical dose dependent uricosuric effect. That is a dual response they are producing. This is a typical kind of effect which are seen by the salicylate. In a low dose, they decreases the urine excretion and increases the plasma urate level in a low dose. So by producing a acid, by changing the acid base balance in a low dose, they produces the urate excretion, decreases the urate excretion. So urate will be retained inside your body and there is a increased urate production inside our body in a low dose. Whereas in a higher dose, the same compound produces the uricosuric effect and lower the plasma level. So in a low dose, they elevate the uric acid level, whereas in a high dose, they depresses the uric acid level. As far as the effect on the blood is concerned, continuous long-term use prolongs the bleeding time. Ultimately, this is due to the platelet aggregation factor which we have seen in previous. Aspirin is contraindicated in hepatic insufficiency. Here only we have seen that is they produces the hepatic injury, hypoprothrombinemia, vitamin K deficiency and hemophilia. These are the effects which are found out by the continuous and long-term use of aspirin onto the blood. As far as the use of this salicylate is concerned in rheumatic arthritis, effectively treat the fever which is associated with the rheumatic arthritis, but fails to protect the progression of a disease, because the progression of a disease will be not stopped by the that is rheumatic arthritis progression will not be, but it is used in the fever. The fever will be reduced and the tissue damage and the progression of disease will not be there. Suppression of antigen antibody reactions will be observed. High dose decreases the antibody production, antibody aggregation will be inhibited and antigen induced release of histamine will be blocked. So these are the effects which is found in the rheumatic arthritis condition. As far as the metabolic actions of this salicylate is concerned, oxidative dephosphorylation, carbohydrate metabolism and nitrogen metabolism, fat metabolism, these are the sites where this salicylate will work. They couple for the oxidative processes in oxidative phosphorylation. They liberate the oxygen and depresses the ATP related reactions. Whereas the carbohydrate metabolism is concerned, the high dose causes hyperglycemia, elevated glucose level, glycosuria, and depletion into the liver and muscle glycogen. So glycogen which is stored into the liver and muscles will be depleted by using the aspirin. In high dose also they produces the negative nitrogen balance and reduces the lipolysis. These are the metabolic effect of the salicylates. Then the effect of this salicylate on the endocrine system is concerned. The large dose stimulate the steroid secretion by adrenal cortex through hypothalamus. So steroidal hormone secretions will be stimulated using the salicylates. Increased plasma level of corticosteroids. High dose also decreases the uptake of iodine, which may lead to the goiter type of conditions. So goiter will be induced. There will be increased adrenocorticosteroids level, or steroidal secretions will be increased due to the salicylate. Salicylate produces local irritation of the skin due to its acidic in nature. They irritate the skin, but this irritation property of this salicylate will be taken account as a therapeutic agents and to the mucosa, and they destroyed the epithelial cells locally, and this is taken as a keratolytic action, but this keratolytic action is taken as a therapeutic property in the treatment of wart or corns or the fungal infection. Whenever they are given for the fungal infection, it is given with the benzoic acid. Here, due to this local mucosal irritation and keratolytic effect on the epithelial cell, they swell the tissue and softens, and later on they become necrotic and they will be destroyed later on. So in the treatment of wart and corns, they will be used as a local agent. They possess the antiplatelet action, one of the best action which is found over here, and in the low dose they prevent the aggregation by COX-1 inhibition. The mechanism we have already seen, responsible for thromboxane formation. Thromboxane formation will be inhibited, and by that way the platelet aggregation will be blocked. As far as the pharmacokinetic properties of this is concerned, they are well absorbed orally and applied topically, distributed widely all over the body. They are metabolized into the liver and converted to salicylic acid, glycine conjugate of the salicylic acid, converted to oxidation product. Alkalinization of urine increases the renal elimination, and the basis of maybe the basis of salicylate toxicity of this. That these are all about the salicylates compounds, but some of them are the non-acetylated salicylic acid. Whatever we have seen is acetylated salicylic acids, the effect of acetylated salicylic acid, that's acetyl salicylic acid, or also known as an aspirin. Now here we will see the effect of non-acetylated salicylic acid. Example of these compounds are magnesium chloride salicylate, or choline salicylate, or magnesium salicylate. We can see they have the effective anti-inflammatory property, but these anti-inflammatory properties of non-acetylated salicylic will be definitely less than that of aspirin. Their cyclooxygenase ability is also less, have the minimal gastrointestinal side effect, and safely can be given in the patient of the asthma, because acetyl salicylic acid mainly precipitates the bronchoconstriction. This is one of the typical side effects which will be also in further. As far as the clinical applications of these agents, that is salicylic acid and their derivatives is concerned, they are effectively in reducing the elevated body temperature. There is a preferred drug in headache, toothache, or inflammatory conditions which are arrived from the integumentary structure, that is skin, and the migraine type of pain, which is effectively reduced by the salicylate. They are extensively used in rheumatic arthritis, osteoarthritis, as spondylitis to reduce the fever and pain only. But remember well over here is that they are not responsible for the cause reduction of this disorder. It is one of the well inhibitor of a COX, that is COX inhibitor, this which is leading to the antiplatelet aggregated action, antithrombotic effect it is giving, and therefore it is used in primary prevention of myocardial infarction, unstable angina, stable angina as a prophylactic and as a post disorder conditions. This anti inhibitory of the COX inhibitor action or antiplatelet action, it is applicable over here. So there are various disorder which are related to cardiovascular system. In secondary conditions they are used, like here we have already mentioned prevention of myocardial unstable angina, stable angina, stroke, transient ischemia, deep venous thrombosis, colon cancer, migraine, inflammatory bowel disorder, ulcerative colitis, where this platelet aggregating factor is more important and participate in the pathological conditions. So COX inhibitors will be more clinically useful over here. Now next to it is the selective COX-2 inhibitors. But these are the having the devoid of gastrointestinal side effect, epigastric distress or heartburn, ulceration. These side effect will not be observed whenever the COX-2 selective COX-2 inhibitor will be taken. Non-selective inhibitor will have this side effect due to inhibition of a cytoprotective prostaglandin synthesis blockade. So prostaglandin synthesis will be blocked, cytoprotective prostaglandin, and therefore they will give you the side effect. Selective COX-2 inhibitor also have the analgesic, antipyretic and anti-inflammatory property, like celecoxib, which is 10 to 20 times more selective for COX-2 inhibition, refecoxib, which is a potent COX-2 inhibitor and also indicated as a non-steroidal anti-inflammatory agent, but they have a serious side effect in CVS. Next to is eterococtib. It is a second generation COX-2 inhibitor which is having the elimination half-life which is more point future, that is 22 hours of elimination half-life, very long duration of action, which is having anti-inflammatory actions, osteosporosis, rheumatic arthritis, skeletal muscle pain where they are widely used, gouty arthritis, which is a better tolerated drug and shows the minimal gastrointestinal as well as serious side effects. So eterocoxib is preferred drug in these three. As far as the adverse effect is concerned, typical adverse effect of the salicylate is salicylism. Long-term use with the high dose of the aspirin, which is leading to the salicylism. Which is nothing but the iodosyncratic reactions, which is not the features of this iodosyncratic reaction is sweating, confusion, dizziness, headache, tetanus, gastrointestinal side effect like paresthesia, respiratory stimulation, CNS stimulation. So these typical sign and symptom were obtained whenever there is a long-term chronic use with a high dose of salicylate, and combined together it is known as a salicylism. As far as salicylate poison is concerned, single or very large acute dose of aspirin, if it is taken, which is leading to the salicylate poisoning, and children are more susceptible for the salicylate poisoning. And the typical treatment which is involved in this salicylate poisoning is gastric emptying, gastric lavage, activated charcoal, and these are the typical universal antidote kind of things which is given. Oxygen supplement and bicarbonate supplements they are given. Other adverse effect, as far as the gastrointestinal adverse effect is concerned, nausea, vomiting, abdominal pain, which is also called as a epigastric distress, heartburn, ulceration, proliferation, bleeding into the GI tract, or by and all these are typically induced by inhibition of COX-1, that is cytoprotective prostaglandin synthesis inhibition. They, in a rare cases, they also provide the hypersensitivity reactions, which includes the anaphylactic reaction, cutaneous rash, iodosyncrety, precipitation of asthma. These kind of hypersensitivity reactions also they produces. Bleeding reaction is also a typical adverse reaction of salicylates. Excessive abdominal bleeding may be observed. Hemophilia, anemia, which is leading to liver disorders, inhibition of platelet aggregation may lead to the bleeding through the nose and gums. These kind of things which is also observed. And as far as the renal complication it is concerned, it is leading to proteinuria, excessive loss of protein through the urine, papillary necrosis, intestinal nephritis. Risk is more with the patient with a CSF and renal insufficiency. So these are the typical adverse effect of the salicylates. So here we finished the first part of the non-steroidal anti-inflammatory agents and salicylates as an NSAIDs. See you in the next part. Thank you very much.